Hello, welcome to Ace of Spade Can Break the Heart, a common presentation of apical hypertrophic cardiomyopathy. My name is Dr. Nagwa Abou-Ghanem, and I'm a second-year internal medicine resident at Amita St. Francis Hospital. Apical hypertrophic cardiomyopathy composes only around 10% on the spectrum of the most common genetic cardiac disease, hypertrophic cardiomyopathy. Prevalence of apical HCM has surged due to increased awareness, advanced imaging modalities, and longer life expectancy. Recent studies reveal that apical HCM is actually less benign than was thought. Its diagnosis tends to be delayed or even missed, putting patients at risk of sudden cardiac death and complications. A better understanding of this disease and timely management will reduce morbidity and mortality of these patients and at-risk family members as well. This case presentation is about a 63-year-old Hispanic male who presented for a first-time outside hospital cardiac arrest. Rhythm in the field was ventricular fibrillation, and ROSC was achieved after one shock. He was immediately brought to the ED. He has a history of paroxysmal atrial fibrillation, diastolic heart failure, and stable aortic aneurysm. He has had prior history of chest pain, and workup in the past included cardiac catheterization revealing insignificant stenosis and ectopic coronary arteries, T-wave changes on EKG, and a non-diagnostic transthoracic echo. He was vitally stable. He was intubated and sedated but breathing over the vent, with sinus rhythm on heart monitor. Physical exam was unremarkable for murmur, added heart sounds, pulmonary crackles, or peripheral edema. He was neurologically intact, but sedated. CT head was unremarkable for acute intracranial pathology as well as chest x-ray, which was unremarkable for pleural effusions, cardiomegaly, opacifications, and pulmonary edema. Labs were significant for a creatinine of 2.02 on a comprehensive metabolic panel and a glucose of 249. Complete blood count was normal. High sensitivity troponin on admission was 32 and increased to 439 after 3 hours, likely due to the chest compressions, or maybe he had a STEMI. EKG was unchanged, and EKG on presentation is actually seen here at the bottom of my poster. Patient is in sinus rhythm at 84 beats per minute with deep T-wave inversions in the lateral precordial leads, V4, V5, V6, and he also does meet criteria for left ventricular hypertrophy. He was immediately begun on a heparin drip for T-wave and nonspecific ST changes. He was placed on an amiodarone drip for ventricular fibrillation, and he went for an urgent cardiac angiography. Angiography was actually unchanged. His coronary arteries still had insignificant stenosis, and the catheterization redemonstrated his anomaly, where the left ascending artery directly came out from the left coronary sinus. There is no left main artery, and the right coronary artery had an ectopic left circumflex artery. Left ventriculography revealed an ace of spade-like formation filling at the end of diastole, and an apical transthoracic echo view confirmed LVH with disproportionately increased thickening, obliteration, and contractility of the apical wall, best seen at the end of diastole. These findings, along with reassessment of EKG, led to the diagnosis of apical hypertrophic cardiomyopathy. An AICD was placed and he was referred for outpatient EPS. The diagnostic dilemma of this rare presentation is potentially life-threatening. Chest pain is a common symptom, and EKG changes tend to be misinterpreted as perfusion deficit. The distinct deep T-wave inversions in the precordial lateral leads can be overlooked or missed. Criteria of LVH can also be present. Transthoracic echo poses a 40% risk of a false negative. Structural alterations at the apex can be difficult to identify, and actually cardiac MRI has the highest sensitivity in detecting this pathology, as seen here below, where this is the image of the left ventricle at the end of diastole, and this is the image of the LV at the end of systole. Notably, apical hypertrophic cardiomyopathy lacks left ventricular outflow tract obstruction, constituting only about 30% of HCM. Complications include diastolic heart failure, atrial fibrillation, apical aneurysm, ischemia, and sudden cardiac death. Again, the classic ACE of Spade configuration on LV-gram at the end of diastole is pathognomonic. Comprehensive SCD risk stratification to determine ICD placement can be life-saving in severe forms. HCM specialists and family screening is also vital in management, and electrophysiological studies should be considered to reduce the risk of tachyarrhythmias and sudden cardiac death, thereby improving longevity outcomes. Thank you.